Let's do it. Back at it, a Krispy Kreme. Da 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 ba. All right. Okay, what's next? Okay, warm antibodies.
IgG.
So, what the heck are warm antibodies? Most are primary/idiopathic. Can be associated with other disorders, autoimmune disorders, B-cell malignancies, infections. Can be associated with medications, penicillin and cephalosporin. Cold agglutinins, typically IgM, bound to red blood cell membranes better at lower temperatures. Okay. So, warm antibodies. Antibodies attach better. Alright, so let's do this. Warm antibodies versus cold antibodies. Okay. So warm antibodies attach better at 37 degrees Celsius, and they are typically IgG. Phagocytosis of red blood cell, dominantly in spleen, often has spherocytes. Oops. Did I break this? How did I do that? Oh well. Alright, smear has spherocytes. So spherocytes are with warm antibodies. Why? I don't know. But probably because of
extravascular stuff, maybe?
yeah. Let's see. Most are primary/idiopathic, can be associated with autoimmune disorders, so penicillin, cephalosporins. So autoimmune and HIV, B-cell malignancies. And then associated with penicillin. And then what comes along with penicillin a lot of times? Cephalosporin. So, all right, warm antibodies bind at 37 degrees Celsius. They're IgG. Spherocytes are common. B-cell malignancies, autoimmune, HIV, penicillin, cephalosporins. Whereas cold agglutinin antibodies, IgM. So we're getting even more complement here on the cold antibodies. Bind to red blood cell membranes better at lower temperatures. Bound IgM will fix complement, which remains on red blood cell at higher temps, plus DAT with C3. So this is both intra. Oh, this is just extra probably, because it's mostly in the spleen. Spleen. So we got extravascular hemolysis. Whereas this is both intra and extravascular. So that's interesting to know. Commonly due to underlying lymphoproliferative disorder. So, lymphoproliferative disorder. And infections too. So both of them can deal with infections, but this one specifically mycoplasma, whereas this one is HIV.
Mycoplasma and mono.
Oh, okay. On her slide it's only mycoplasma, but hey, the more information the merrier. Warm. Okay. Oh, I did it again. Shoot. Warm. Okay, so for warm, oh, I need to do this real quick. Oh man, my back. Alrighty, let me just take this and there we go. There we go. All right. So this one, warm, deals a lot with opsonization because IgG is an opsonizing antibody, so we get macrophages in the spleen. So that's where the extravascular hemolysis comes from. Goes along with that. And then the cold bind to the eye antigen on erythrocytes and temperatures are at or below 37. That's not right. That's an hallucination. So this one is intravascular because it's complement fixing. It gets C3 on there, which would lead to vascular. So it's mostly intravascular. Mostly intravascular. See if that's it for this. Okay, yeah. So warm antibodies, 37 degrees Celsius, IgG. Smear has spherocytes. It's by autoimmune, by HIV, by B-cell malignancies. Also by medications such as penicillin and cephalosporin. The spleen does most of the phagocytosis, so extravascular hemolysis via opsonization by IgG, whereas cold antibodies are IgM, and it's mostly intravascular hemolysis because of the C3 complement fixing. It can be caused by lymphoproliferative disorders and then infections such as mycoplasma. So warm antibodies, looking away from the board this time, deal with IgG antibodies, and that leads to opsonization, which in the spleen leads to extravascular hemolysis, and this can be associated with autoimmune problems and B-cell malignancies and HIV infection. Also, penicillin and cephalosporins can cause this, whereas cold antibodies are IgM, mostly complement fixing, so C3 stays attached on the red blood cell membrane, leads to intravascular hemolysis, and it can be associated with lymphoproliferative defects. And that's all I know. Oh, infections such as mycoplasma. Okay. All right. So peripheral smear showing spherocytes. Alright, so we'll talk a little bit about hereditary spherocytosis. Alright. Hey. Kicking her feet. Kicking her feet.
What?
Alrighty. Now let's go on to hereditary spherocytosis. Hereditary spherocytosis. Now, what is hereditary spherocytosis? I don't really think we need to worry about the incidence, to be honest.
No.
Dominant, recessive, or de novo mutations in genes encoding red blood cell membrane proteins, and chirin, band 3, spectrin, and protein 4.2. So we've got 4 proteins of interest, and they can be dominant,
Oh, there's someone down.
yeah, auto, dominant, recessive, or de novo. And it's a defect in chirin, spectrin. Alright, spectrin, band 3, and what, protein 4.2? Yeah. Protein 4.2. So those proteins are affected, one of them for... And what's our clinical picture? Clinical picture. A clinical picture of hereditary spherocytosis, which is a defect in enchirin spectrin band 3 or protein 4.2, is anemia, varying severity. Splenomegaly. That would make sense. Gallstones. That doesn't make sense to me.
Do you think this has to do with bilirubin?
Yeah, probably. That makes sense, actually. And then spherocytes on smear. That's an obvious one. So anemia, because they're having hemolysis. Spherocytosis, because it's spherocytosis. Gallstones, because we think the bilirubin is increased, which makes sense. And then the last one is splenomegaly, because of all the blood cells getting removed by the spleen. So, if we're drawing someone who has that, they got a big round head, they got a big old spleen, not liver. They got a big old spleen. They got gallstones, so they got a big old gallbladder. And they got anemia, so they look really tired like me. Alright. That's our clinical picture of HS. So they can have an increased MCHC, which is our concentration of hemoglobin in a group of red blood cells. Increased osmotic fragility, eosin 5 maleimide binding test, DNA testing panels, total versus subtotal splenectomy. So, things to be aware of are normal MCV, increased MCHC, increased osmotic fragility. That's the stuff we need to know for this. Anemia, splenomegaly, gallstones, spherocytes, normal mean corpuscular volume, increased mean corpuscular hemoglobin concentration, and then increased osmotic fragility. And you're going to do a splenectomy for these guys. So, pretty obvious treatment. Splenectomy. Well, bam. Okay. So the osmotic fragility test, let's talk a little bit about that. So we're going to have increasing concentrations of sodium chloride. And then as it becomes more hypotonic, you're going to get more hemolysis at lesser levels of hypotonicity with hereditary spherocytosis than you would with the normal blood. Alright, case 2. 9-year-old AA boy. Oh, okay. Who presents with fever and tea-colored urine. His mom states that he had a history of neonatal jaundice requiring phototherapy. He's got low hemoglobin, I think. He's got normal mean corpuscular volume. He's got a lot of reticulocytes. It's DAT negative. What is DAT? His mom states that he had a similar episode, so he's got G6PD. Glucose 6-phosphate dehydrogenase deficiency. Most common red enzyme cell deficiency. Wow, greater than 1 million people have it. That's crazy. It's on the X chromosome too.
Lots of fava beans not being eaten.
Lots of flat. What?
Lots of fava beans not being eaten.
More for us. Mechanism of hemolysis. Free radicals need to be reduced. Lack of NADPH allows for free radicals to bind hemoglobin. Hemoglobin denatures. So basically, NADPH is a antioxidant, and without NADPH, you're going to have hemoglobin being destroyed, and that's where Heinz bodies come from. All right. G6PD deficiency. So Heinz bodies are just denatured hemoglobin. We're gonna write that over here. Heinz bodies. What are they? Denatured hemoglobin.
Due to a lack of NADPH.
All right. When shouldn't you check the enzyme activity?
Right after.
During an acute episode.
Right.
Then there's also bite cells.
When macrophages eating the Heinz bodies.
I guess so. So management. What's the management of G6PD? Yeah, essentially, it's prevention. Fortunately, acute hemolysis in G6PD patients is usually short-lived, rarely requires transfusions. Yeah. Okay. What's the second most common enzyme deficiency in red blood cells? Yeah. Nice. Pyruvate kinase.
And that's autosomal recessive.
I have no clue. It is recessive. Autosomal recessive. Good job, Holly. Autosomal recessive. Found in all ethnic groups. And is treated with splenectomy and red cell transfusions. Splenectomy, red cell transfusions. Alright, pyruvate kinase deficiency, autosomal recessive, splenectomy, red cell transfusions. So how do you treat it? Metavapat. Metavapat. So metavapat is an oral activator of pyruvate kinase. That's it for pyruvate kinase. I don't really glycolysis, essentially. Alright, so that's it for that one. 45-year-old male presents with shortness of breath for 2 to 3 days. He's pale and complains of severe abdominal pain. He's got really low hemoglobin, normocytic. His LDH, lactate dehydrogenase, 2306. I don't know if that's elevated or not. Assuming it's elevated. Haptoglobin is less than 6. Oh, so he's probably got intravascular hemolysis of sorts. Reticulocytes 10%. Platelets 180,000. So he's got paroxysmal nocturnal hemoglobinuria.
Encyclopedia.
So only hemolytic anemia resulting from an acquired mutation of a myeloid stem cell. Somatic mutation in the PIGA gene. Paroxysmal nocturnal hemoglobinuria. Okay, so this is a mutation in PIGA. Membrane protein defect, lack of GPI anchor.
Daffy
What's that?
The C3 convertase inhibitor and also the
Oh, DAF.
Daffy.
Oh, yeah. Red blood cells sensitive to complement-mediated intravascular hemolysis. Okay, so we have decreased GPI anchor, which is related to complement. So we're going to increased complement activity. So then we're going to have intravascular hemolysis. And so we're going to have C5, C9 membrane attack complex. So we have decreased GPI anchor, which leads to increased complement. Intravascular hemolysis. Detectable by flow cytoassays. So C55 and CD59, which I don't know where those are found, but found somewhere, are decreased and absent. Eculizumab and revelizumab and pegcetacolopan. Okay, so eculizumab, and revelizumab. These are both C3s and Hibs. And we got a C5 inhibitor, which is our pegcetacolopan. So eculizumab and revelizumab are C3 inhibitors, and pegcetacolopan is our C5. Oh no, it's the other way around. This is a C5 inhibitor, and this is a C3 inhibitor. So, sorry to all of my imaginary fans. C3 inhibitor, pegcetacolopan, P5 inhibitor, eculizumab, and revelizumab. So it's okay. Clinical presentation in paroxysmal nocturnal hemoglobinuria. So we have anemia, which makes sense. And then we have thrombosis. Thrombosis.
Maybe it's like they got rid of the hemoglobin or something because they're peeing it out, so they have an iron deficiency, so there's thrombocytosis. Maybe. Something like that.
Yeah, I like that. I think that's good.
That's just a theory.
Smooth muscle dystonia. Because of the decreased nitric oxide. So there, for some reason, there's decreased nitric oxide. I don't know why. But for some reason in this, there's decreased nitric oxide. I don't remember there's an Anki card about that. Alright. Mechanical hemolytic anemia.
Well, that makes sense.
So schistocytes. So there's a specific. So we gotta remember schistocytes. Specific for mechanical hemolysis. Which can be artificial heart valves, microangiopathic hemolytic anemia, MAHA, vascular malformations, and repetitive trauma. Hemolysis can be due to infections. Approach to hemolytic anemia. So, I'm not gonna read that, come on. Clues to underlying etiology. So schistocytes are seen in microangiopathic hemolytic anemia, trauma, heart valve hemolysis, severe burns, and uremia. Fragmented red blood cell. Alright, so microangiopathic hemolytic anemia. What is that? I don't know.
ANMTS13.
What?
It's like a lack of ANMTS13. And it happened in TTP, right? Like
Yeah.
The platelets get together and then like it gets sheared. The red blood cells get sheared when they can pass through the platelets.
Ah. Oh, man.
Yeah, I see, yeah.
Okay. How jolly bodies are seen in asplenia?
Because the macrophages can't like eat the remnant out.
Why can't they just eat the whole red blood cell?
I don't know, but I mean, how jolly bodies are gotten rid of by the spleen, so if you don't have a spleen, you have them.
Oh, I see.
I
Okay.
think. Let me check that.
I trust you. Heinz bodies.
Yes, that's true.
Like I know what neuroacanthocytosis is.
Yeah, no.
What acanthocyte? What's an acanthocyte? What happens?
It's like the spiky little guys.
But why?
Membrane lipid abnormalities.
Mm-hmm.
So acanthocytes. Ow. Acanthocytes. Membrane. Lipid abnormalities. Liver disease, neuroacanthocytosis, severe malnutrition, and A beta lipoproteinemia. Alright, well, that's this lecture finished, thank God. Okay, it feels good to finish that one. Alright, what's the next one? Oh, the next one's gonna be a good one. Alright, I'm actually excited for this one. Hemorrhagic fever viruses. Da-da-da-da-da. Da-da-da-da. First, I'm gonna take a break. Go pee. Be right back. You there? Okay. I don't blame you. Can I steal my cardigan back though? I'll keep mine here. Thanks. You can take the bag though if you want. Alright. Yoo-hoo! More studying. Let's do it. Yay. I think we should do Twitch so we can get some people in here. Because I feel like the YouTube one is not... It's struggling a little bit. No new people have come by. What do you guys think? What do you guys think? I think maybe I'll do Twitch. I think it'll be a better one. We'll do Twitch. Alright, I'll be back in a little bit on Twitch.